Hello and welcome to EconVersations. I'm your host, Dr. Dan Sutter of the Johnson Center for Political Economy at Troy University. Medicaid is one of the big three entitlement programs that many people feel threaten the long-term financial health of the federal government. And Medicaid is the largest source of expenditures in Alabama's general fund, and an impasse over funding for Alabama Medicaid may lead to a special session of the state legislature here in 2016. Why has Medicaid grown so much over its 50-year history? And what do the sources of growth in the program reveal about the potential for reform to curb spending growth without compromising the health of the 70 million or so Americans who use the program? Joining me on the show today to talk about the growth of Medicaid is my colleague, Dr. Dan Smith, the Associate Director of the Johnson Center. Welcome back to the show, Dan.
Thank you very much, Dan.
Well, actually, we're going to change things up a little bit today because you'll be asking the questions and asking me about a study that I've recently done.
Mm-hmm. Yeah, I'm very excited about this. This is a particularly important issue in Alabama and across the nation. Healthcare costs spiraling out of control, and one of the big elements of this is obviously Medicaid. Mm-hmm. Can you tell us, Medicaid is usually it's one of the big three entitlement programs. What does that mean, and can you give us a little history on what Medicaid is?
Sure. Well, Medicaid was established in 1965 under the Johnson administration. So here we have a picture of the signing of the bill. It was established at the same time as Medicare. And the goal of Medicaid was that it was going to provide provide medical insurance for a number of different populations. So the poor children, pregnant mothers in poverty, as well as disabled Americans. So there are a number of different core populations that are sort of covered under Medicaid. It's a little different from Medicare, whereas Medicare is exclusively a federal program. Mm-hmm. Medicaid is jointly run by the federal government and the states. And we'll get into some of the funding details of that as we go along. But that's why we both hear Medicaid being discussed as a important policy for Washington, D.C. Mm-hmm. And then it's also being discussed as an important issue here in the state of Alabama, given the large amount of money that comes out of the state general funds to support Medicaid.
Mm-hmm. So just to clarify, Medicare is a strictly federal program administered by the federal government, but states are involved in funding part of Medicaid?
Yes, so there's a shared funding and also shared governance, mm-hmm. and that is going to end up being important for a part of the recent Medicaid expansion. There's shared government. We actually have state programs where the states sort of administer the Medicaid program, but they get a lot of their funding under rules mm-hmm. for eligibility for that funding that are set by Washington. So there's both a federal level and a state level of this mm-hmm. policy. And it is different. And Medicare, by contrast, is the purely federal program that that provides medical assistance or health insurance for elderly Americans.
Mm-hmm. All right, before we get into the nuts and bolts, can you tell us about the general trend, both in terms of how much we're spending on this program? Is it increasing, is it decreasing, and the percentage of state budgets and federal budgets as well?
Sure. Medicaid began in 1965, and it was regarded at the time as sort of like the junior cousin of Medicare. Everybody thought Medicare was going to be the much bigger, much more significant program. Medicaid was definitely its more junior cousin. Mm-hmm. But spending has grown significantly over time. And today, in total, between the federal spending and the state spending, it's on the order of about $500 billion. This is showing the growth in Medicaid spending as a share of our national health expenditure. So if you take all the money that our nation spends on Medicare every year, or medicine in total, and say how much of that is coming from Medicaid, and we can see that that's approximately doubled from the beginning. Within the first few years of the program, we were spending about 8% of that. That share of total medical spending in the country has approximately doubled. And of course, that's at the same time which medical spending overall has been going up significantly and much faster than inflation. And so there's been not only has Medicaid been increasing as a share of total health expenditures, those total health expenditures have been going up a lot. And another way to think about the size of Medicaid is originally around about 1% of GDP. So to give you the size of the economy, and now it's at about 3%. So relative to the size of GDP, it's approximately tripled. And you can see that that's more than the doubling here, and that's sort of taking into account the fact that we spend much more on healthcare of all different types now than just Medicaid.
So obviously, any discussion of constraining the growth in healthcare costs is going to involve some focus on Medicaid. You mentioned it's an entitlement program. What exactly does that mean, and how does an entitlement program differ from a regular budgetary expenditure?
Sure, that's a good point, and it's an important distinction to understand. On any type of entitlement program, what the program creates are conditions, sort of like statutory or legal conditions under which somebody would be eligible for the program. And then certain benefits, or whatever the specified level of coverage, and coverage for different types of procedures and so forth. And so under the entitlement program, anybody who meets those criteria laid down in law can enroll and become automatically covered. And then spending on the program ends up being however much is necessary given the number of people that are enrolled and the number of covered procedures that they end up having to have in 1 year. By contrast, in other programs, sort of in the normal budget process, Congress or the state legislature would have to appropriate the money, and so they'd only an agency would only have as much money to spend as it gets appropriated, and so there's always the potential that, at the end of the year you've spent all of your money. But under an entitlement program, that can't happen because whoever's eligible, based on the criteria in the program, is automatically covered. And then the flip side of that is that if you want to reduce spending on the program, what you have to do is, in effect, sort of change the who's eligible for the program, who's entitled to enroll, or what the level of covered benefits and level of reimbursement and so forth that would be involved with the program.
So essentially, anyone that is qualified for the program can enter it and be automatically qualified to receive the benefits. So essentially, that presents a problem in terms of the budget because it could be essentially endless as long as people are eligible for the system.
Yes. So you do try to make estimates of what would be the eligible population if everybody enrolled. But the enrollment percentage isn't 100%. So there's always, even amongst people who are currently qualified, it's between 90 and about 97% across the different states of people who are actually eligible go ahead and enroll. And so it is hard to forecast. And so especially then, when the economy goes down and people lose their jobs and lose their regular health insurance, they might all of a sudden become eligible for Medicaid. And expenditures under the program can go up at a time then when state budgets are under a lot of pressure anyway, and states face balanced budget constraints. So not surprisingly, Medicaid is proven to be a really, really big budget buster for the states, and particularly at times when the economy goes down, because that's when Medicaid spending is likely to jump as more people become eligible, and then state budgets become really tight.
Yeah, so your study put out through the Mercatus Center at George Mason University kind of lifts up the hood and tries to figure out what's actually driving this trend in increased expenditures on Medicaid. Can you give us just briefly what is driving these costs? Sure.
So the brief issue is going to be is that the structure of Medicaid appears to be driving the expenditures a lot, and that's going to end up being important because one of the reasons we wanted Mercatus was interested in undertaking this study was to by looking at the history and the research that exists to examine the determinants of Medicaid spending and Medicaid spending growth, see if there was any evidence, any fingerprints or footprints you might see in the evidence to suggest that the structure of Medicaid has been particularly driving the growth. Because alternatively, one of the things that could be driving the growth of Medicaid spending is simply maybe more people being eligible for the program. And so if we've had fluctuations in the poverty rate or the growing expenditures for the cost of medical care overall, or the fact that there are a lot more medical procedures that can be done now than in the 1960s, and that they're very costly. So it was medical need that was driving the growth of spending on Medicaid, then that would mean that reform would be a much tougher or harder choice. I mean, to cut back on the growth of spending, if it's all medical need that's been driving the growth of Medicaid spending, would mean you'd have to essentially cut back the benefits that eligible Americans would be getting, either reduce the number of people being eligible, reduce the level of coverage, reduce some of the services that they have, and that could be painful. But given that it's the structure of Medicaid, the structure of this joint federal-state program that seems to be have driven a good part of the growth, that means that there's really some potential real gains from for our country from reforming Medicaid.
Yeah, so I want to get into more specifically what you're talking about, the structure of the system, and I assume it's wrapped up with the funding, how it's set up, where the funding is done through grants through the federal government. Can you tell us what that specifically means and how that affects the increase in costs?
Sure. Yeah, we'll try and get into this. It's a little of a bit of a technical or dry subject to get into this question that economists talk about of matching grants versus block grants. So Medicaid is this joint state and federal program. About around 2/3 of the funding for the program nationally comes from the federal government. It varies across different states. So what that means is that there's a formula by which the federal government allows states to be eligible for the funding across different for their Medicaid programs. And what's important in all this is that Medicaid has a structure of what's known as a matching grant system. What that means is that for every dollar that a state spends on their Medicaid system, the federal government is going to match that spending. Now, the level of the match varies across states according to what are known as federal medical assistance percentages. And so the lowest percentages are at 50%. So the highest income states have a 50% match. So that means that they get one federal dollar for every dollar that they spend themselves. Or the cost of Medicaid in the highest income states are going to be shared between the state governments and the federal governments. In Alabama, our percentage is around 67%. That means that we're getting about $2 federal dollars for every dollar that we spend. And then Mississippi happens to have the highest percentage across different states, and that's just short of 75%. So that means that in Mississippi, they're getting $3 federal dollars for every dollar that the state spends. The federal matching percentages are set, sort of inversely set based on your income. So the lowest income states have the highest matching rate so that they can get more federal assistance. So it ranges between $1 and $3 in terms of the match.
So when the federal government says, I'll pay you $2, $3 for every $1 you spend, what type of incentive does this provide for the states when it comes to healthcare expenditures and Medicaid?
Well, that's an important point to realize now, because that means that the state legislators, state governors, decision makers across the different states are spending anywhere between maybe half or maybe as little as a quarter of the cost of Medicaid in their state. So if they allocate $100 million to their state Medicaid program, they would get at least $100 million, perhaps in Mississippi as much as $300 million from the federal government in the match. And that means that every dollar that states allocate to Medicaid brings in a lot of extra spending for the federal government. And that's been shown in some of the research that's been done to have really distorted state policy making over time. That what we've seen is that Medicaid has become an increasingly larger share of state budgets. But a part of that story is all the political economy. The fact that as a state legislator with that federal match, you can get credit for spending, or you can in effect spend $2 for every dollar you allocate. Whereas if you look at something else that the states fund entirely themselves, then they have to pay the full cost of that. And so it's something where they would be paying the full cost of an expenditure, they get $1 of expenditure for every dollar they appropriate. In Medicaid, they're getting $2, $3, or even $4 of spending for every dollar they appropriate. And that's been sort of like a magnet, sort of attracting a lot of state dollars over time, simply because for state politicians, it's an attractive way to get more bang for their buck. And conversely, then it also means that states don't consider the full cost of what they're doing. So they can end up adopting or expanding Medicaid in ways to cover things that aren't providing a lot of benefits or the full benefits to their residents of their state.
Given that the program is, well, it's funded in part by the federal government, in part by the states, but it's administered by the states, how much discretion do they have to structure the program in order to experiment with new ways to provide Medicaid services?
That's a really important point, because and this is an important point that comes up in a lot of the studies of the effects of different variables on Medicaid spending across the states. In Medicaid, there are what are known as required services or mandatory coverages that the federal government has, and then there are other things that are called optional coverages. So And the federal government is setting the rules. And part of the rules is that the federal government says you have to provide certain types of basic services. And these are mandatory. All states have to do this to be eligible for the federal dollars at all. And so if you look at things like physician services, laboratory and x-ray services, inpatient hospital services, outpatient hospital services, sort of like the core things, all states have to spend dollars on those things. But then there are a lot of optional coverages. And for these, I think all states offer prescription drug coverage, but the level of their coverage varies. And for some of these other things, chiropractic services or eyeglasses, whether they cover eyeglasses or dental coverage, there are a number of states that don't do this. So some states are covering it, other states aren't. And it's really going to be in the optional spending that you can see a lot of the evidence of the matching grant structure of the program or political influences on which states are adopting these programs. On the mandatory spending, it's going to be largely driven by medical need. These are things that the federal government says you have to cover these services. There are also some required populations that states are required. You have to cover all pregnant women. You have to cover all children in poverty. You have to cover the disabled. But the states have discretion over whether they want to cover poor adults. And in Alabama, we have one of the lowest threshold. We have one of the most strictest coverage limits for poor adults to get coverage. They have to be below about like 13% of the poverty limit. So you have to really almost be making no money to be eligible as simply a poor adult for Medicaid. But other states have much higher levels of coverage that they can cover. That they might be covering. People are up to perhaps as much as 200% of the poverty limit, even before the recent Medicaid expansion.
So given these discretionary elements in these optional coverages, you have to be really careful when comparing Medicaid programs across states when you're looking at trends in healthcare expenditures.
Exactly, and some of the studies that failed to make this distinction don't end up showing very much of an effect of state-level variables on total Medicaid spending. And that's not surprising, because if you're trying to look and see, well, does it matter if Democrats or Republicans are in charge of this state, or does the matching rate matter for this state versus that state? If you're looking at things that the states have to spend the money on, the federal government says you have to cover these people and you have to provide these services, then states have no discretion. So state variables like who's in charge of the state government simply aren't going to matter, or the influence of interest groups or lobby groups in different states simply is not going to matter.
So one of the really prominent discretionary elements that we've seen in the news recently is the Affordable Care Act, the option for states to expand Medicaid coverage. This seems fairly divided. Some states are adopting it, some states aren't. What's driving that?
Well, yeah, that's a good thing, because again, it also illustrates this optional nature or the complicated structure of the Medicaid program. Because under the Affordable Care Act, the idea was that they wanted all states to cover poor adults up to 133% of the poverty line. And so, but it turns out that given the nature of the system, that the federal government couldn't actually dictate this to the states. They couldn't, and furthermore, they couldn't withhold funding from the states for their existing Medicaid programs if they didn't expand the Medicaid. So this essentially meant that the expansion had to be optional or voluntary at the state level. And so this ended up being very contentious. And again, that was the type of decision where we could expect to see state-level variables affect this. And many Republican-dominated states, not all, but many Republican-dominated states resisted expanding Medicaid, like we did here in Alabama. Although some states where you had Republicans in charge did also expand the program to cover the poor adults up to the threshold, the 133% threshold.
So looking at these studies that actually control for these discretionary elements, what's the consensus in the literature on what's driving these healthcare costs? Is it something in the structure of Medicaid?
Yeah, it surely appears to be, because if you look across the states, probably the most careful study was done by a political scientist named Thad Kusser, and he was able to identify just exactly what the discretionary spent element of Medicaid spending each year in each state was versus their mandatory spending. So by dividing this up this way, it was a nice clean test to be able to look and say, this is what the states have control over, this is what they don't. And so what he found is that if you compare the states with the lowest matching rate, the 50% matching rate, versus the states with the highest matching rate, like Mississippi, that if you moved a state from the lowest rate to the highest rate, in other words, lowered the price, lowered the cost to state lawmakers of expanding Medicaid, then Medicaid would end up being about 22% larger. The state's discretionary spending would be about 22% larger than in the highest states. So that's a pretty big chunk of discretionary spending. And again, that would be money that's attributed to the matching grant structure of Medicaid.
Mm-hmm. How much political influence is involved in this?
Well, again, once Professor Kusha breaks this down into discretionary versus optional or mandatory coverages, he found that things like whether Republicans control the state house or the state governorship matter a lot. And he looked at a number of different political variables, and if you would move a state from what's known as the 25th percentile, so say below the average, to above the average at the 75th percentile, that would increase discretionary spending, excuse me, in the state by about 23%. So again, politics matters, and so ideology or preferences toward the size of the welfare state, assuming the Democrats maybe in general are more favorable to a larger welfare state or larger entitlement programs, that does come through, and we see strong evidence of that in the discretionary spending.
Mm-hmm. What role, if any, do special interest groups like the American Association for Retired People play in driving these healthcare expenditures?
The interest groups play a role, and in the studies that can look at these discretionary elements do find evidence of that. But it's one where you have to be very careful, because when you look at these, say, the different voluntary or optional coverages for the states, if a state is considering expanding to cover an optional coverage, then it's possible, and there is a lot of evidence that emerges in the studies, that as you expand coverage, you actually reduce reimbursement rates, you reduce spending on some of these required or mandatory coverages. And that means that it's not obvious if you simply think like, oh, well, doctors should be in favor of expanded Medicaid or all these different expansions of Medicaid. Well, it's possible that their services are already being covered. And then when you look at an expansion of Medicaid to more generous prescription drug coverages, well, that could actually end up hurting the physicians or the hospitals. And so you have to be very, very careful in trying to look for evidence of interest group spending. But we do see a lot of evidence. And we actually see some evidence based on some of the spending patterns on Medicaid that perhaps the AARP, as you suggest, the American Association of Retired Persons, could be having a big influence on spending.
Mm-hmm. So controlling for politics, controlling for special interest groups, controlling for these discretionary elements, how much remaining influence does the grant structure, provide for the growth in these Medicaid expenditures?
It could be quite significant. And to get this, so yeah, clearly the matching rate matters, but I think one thing that you run into problems if you're trying to look empirically across states is that all states have at least a 50% match, right? They're all of this, so there's no state that's paying the full cost on the margin, the full cost of expanding Medicaid on any of these various different discretionary margins. They're all even the highest income states like Massachusetts and New York and Connecticut get 50% federal coverage. And I think that even when you go to the highest income states, you see a lot of evidence that they've expanded their program to be a lot larger than it would be if they were paying the full cost out of their own funds. And to see this, one of the things you can see is, although we normally would think that Medicaid is a program that's designed to cover children and the poor adults, but actually about 2/3 of the spending on Medicaid goes to cover the elderly and the disabled. Now, the elderly are also eligible for Medicare. They're what known as dual enrollees, that if you're a poor adult, then you can, if you're a poor retiree or a poor elderly person, then you can actually get coverage under both things. And one of the areas specifically where you see a lot of evidence of this is if you look at nursing home expenditures on nursing home care. So this is a chart just showing, if you break down the most recent year the data is available in 2014, all of the spending that's done in the U.S. on nursing home care. And you can see that the Medicaid is the largest source of that expenditure. Actually, a good chunk of it's paid out of pocket by people out of pocket. More than a quarter of the funding comes out of pocket. But Medicaid spending is covering almost a third of that. It covers more than Medicare. And what this involves is that elderly who have insufficient assets or who can qualify for the Medicaid coverage can have their nursing care coverage, nursing care paid for out of Medicaid. And that ends up being a significant draw on Medicaid's funding. A lot of Medicaid's funding is going to cover the elderly and also the disabled populations. Disabled elderly would be another portion of who's getting Medicaid or who's getting nursing home coverage. And there you might see, in this you might see actually sort of the influence or the footprints, the fingerprints showing that the AARP could have been involved here. Because one of the puzzles for the expansion of Medicaid from a political economy or interest group standpoint is that most political scientists or most careful observers of U.S. politics would argue that, well, the poor are a relatively uninfluential interest group. But a lot of times you can see a lot of groups will step in and say they're trying to help out the poor, but they're actually getting assistance for themselves in some way. And so maybe it's not surprisingly, given that the poor aren't a very strong interest group, that we've seen a lot of Medicaid dollars actually end up getting diverted into coverages for the elderly. And so a strong and effective interest group is actually lobbying to capture a lot of these Medicaid dollars that maybe the average citizen might be thinking, the average American might be thinking is going to cover, like the poor children and pregnant mothers and other poor Americans.
Mm-hmm. So your study also touches on potential reforms to kind of reverse or constrain this growth in Medicaid expenditures. One of the proposals put forth is block granting. Can you explain what block granting means and tell us if you think it would be helpful to help reform this program?
Sure. Block granting, I think, refers to a structure where the federal government would simply specify or set an amount of money that a state is going to get under their block grant, for their Medicaid program. And then that would be fixed maybe for a number of years at a time. And then the states would have that much money, but no more. If they want to expand coverage and they don't have enough money from the federal government to pay for it out of their block grant, they'd have to pay the full cost out of their own state funds. And so when we had welfare reform in the United States back in the 1990s, what happened was that we switched to welfare, or cash assistance programs, from a matching grant structure to a block grant structure. And that's been quite effective in constraining the growth in welfare spending in the United States. And again, the reason why we would see this, and we expect to see this with Medicaid, is that now states would be responsible for paying all of the coverage, all of the cost of expanding coverage to optional coverages or optional groups out of their own funds. Now, that doesn't mean we're against necessarily expanding coverage for poor Americans, but it would mean that state lawmakers, who are probably in the best case to evaluate the costs and benefits, would have to consider the full cost of this and not be able to pass the costs on to the federal government.
Mm-hmm. Are there any examples of states doing this?
Yeah, a couple of states have been able to move to block grants for their Medicaid program already. I think Rhode Island is the most prominent example. And Rhode Island has helped stem their growth in Medicaid spending by moving to a block grant structure. One of the reasons why you end up doing that also is that not only the matching grant structure not only means that states get to share some of the cost of expanding Medicare, but that also means that they only get to keep a portion of the savings that they get from eliminating any waste. So matching grants are a very inefficient structure. It's one that we would all recommend, identify as inefficient as economists, and it really ends up, I think, driving a large portion of the growth in Medicaid costs that we've observed.
Thank you. Any concluding thoughts?
Well, I think there is a good cause for possible reform, and hope that we could, by reforming Medicaid, provide better care for poor Americans without having to reduce their coverage. Well, thanks, Dan, for coming on, and thank you for joining us. Join us again next time for another EconVersations.